Hello, good evening, good day, good afternoon, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a cardiac surgeon in Yorkshire in the United Kingdom. I'm the director of the Faculty of Surgical Trainers for the Royal College of Surgeons of Edinburgh, and I'm a visiting professor at Imperial College London. Thank you very much indeed to the 3,096 followers across the globe. I do hope by next week we pass the 3,100 mark and ask that you'll share your learning. I sincerely hope that you're practicing as well. I'm going to continue with the philosophy of Miyamoto Mushashi in his book The Five Rings. This is the undefeated samurai warrior, and this is yes and no. Master Longi said to the group, "The pillar of affirmation does not see the pillar. The pillar of denial does not see the pillar. Having got rid of affirmation and denial altogether, attain understanding within affirmation and denial. For these judgments of good and bad are sicknesses of the mind. As long as these sicknesses do not leave the mind, whatever you do is not good. This means that after having detached from affirmation and denial, you should then mix with affirmation and denial, rising from the midst of affirmation and denial to the supreme state." Now, I read this and I thought of the affirmation and denial that always happens in audit meetings when it comes to wound infection. For surgeons don't seem to accept wound infection. And I've sat in meetings where people have argued the red wound was not an infection. A wound with a bit of discharge that is culture negative is not an infection. Unless it's exuding pus, it is not an infection. And I do find this rather troubling. And I do understand the potential stigma that comes from having wound infections. But I'd like to turn the whole argument on its head. Why don't we actually say anything less than a perfect wound is not good enough? Because anything less than a perfect wound is going to require dressings, time, notwithstanding the cost, but the inconvenience and the misery of patients. And certainly for the last 20 years, there's been no change in wound infection rate for sternal wounds, which sits at about 1.6% for deep sternal wound infection. And that carries a mortality of 10.7% versus less than 2%. A stay in hospital that's 4 times as long and a cost that's 5 times as more. But whereas in cardiac surgery people accept there is a risk to life having an operation, because not having the operation there's a risk to life, I put it to you that that is accepted risk, but it's the wound infection that is the problem, and would certainly scare me because of antibiotic resistance. And the Shroud sayers claim that in 10 years' time, because we have not developed new antibiotics and the increase in antibiotic resistance, doing an operation will be like going back 200 years with the risk of infection. Now really this is preventable. Now 200 years, Robert Liston, who graduated from Edinburgh University in 1794, was known as the fastest knife in the West End in Edinburgh. His speed and skill of amputation was such that he could take a leg off in 2.5 minutes. But he is also famed for that 300% mortality, when the knife took the leg off, the assistant's finger off, and cut the coattails of a spectator who died of fright. The patient and the assistant later died of infection. We work in a show-me environment, and I implore you to collect your data and show me. Now this is 3,287 cases on a chart, and I'm plotting my all wound problem. And you'll see that here I introduced a tissue care bundle. And that is where my story starts, because this is another fundamental problem in surgery and in healthcare in general, because that is the way we always do it around here. And in 2009, my assistant was standing opposite me as I was smearing bone wax on the sternal edge to reduce bleeding and improve visibility. And he said, "Why on earth are you doing this?" Because simple understanding of the physiology of wound healing, especially bone, tells you that putting any foreign material between two bone edges is silly. And on reflection, he was quite right. I had always done it like that and had never been challenged. So we sat down together and thought, what else can we do to actually improve the wound infection rate? And we came up with a bundle. Now, I used to use iodine, put it on, and like most surgeons, wipe it off before it dries, which is really counterintuitive. But the evidence shows that chlorhexidine is better than povidone iodine, and it dries a lot quicker. I don't know a surgeon who could stand at a table and do nothing for 5 minutes as a prep dries. But we looked at everything from the pre-op to the operative and the post-operative. The pre-operative, obviously, is antibiotic policy and timing, skin preparation with clippers and not a razor. And the one blip I have here on my flat line is a patient who was coming to electrosurgery, who went off during the night, and we rushed him into theatre, but they took a razor to his chest on the ward, and he had one of the nastiest wound infections I've ever seen because of that. The most important part of surgery is tissue handling and care, as I've been trying to instill in you in the Black Belt Academy of Surgical Skills. To handle tissues with a caress and not be a mere hewer of flesh, as said by Lord Brock. Not only should we collect our data, we should put it up for scrutiny all the time. And I introduced this table for audit, and simply looking at your wounds and scoring the wounds. And on this side, I have discharge, serous exudate, erythema, purulent, with separation of tissues, and across the top, percentage. And put a traffic light system in there: green, yellow, orange, and red. And what we decided to do is at every audit meeting, every month, discuss the red and orange cases, particularly if they had very little in the way of risk factors for infection. Simply by starting to look at your wounds and paying attention to them in audit, we know has a significant effect. We do know there are many bundles, and there is the surgical site bundle. And that starts with a pre-wash. And every patient the night before surgery should ideally have a bath. And I recall patients going into the bathroom, turning the taps on, and sitting in the bathroom smoking a cigarette and not getting into the bath. And I'm also aghast when people come to theatre and I'm prepping their legs to take vein for coronary artery bypass graft and see dirty, smelly feet. This is a simple thing to do, is to put somebody in a bath. And if it's not a chlorhexidine wash, Soap and water will suffice. Clippers, I've mentioned. Glucose management is important. But then in theatre, it's your scrubbing up and gowning. And I do watch the trainees and junior staff scrubbing up because some of it is actually quite frankly poor. And I've seen that amongst senior surgeons too. In particular, do learn to put your gloves on closed and open your hand into the glove. And do remember, when you're drying your arm, your fingertips are clean and your elbows are dirty. And the common mistake I see is people drying their arm like this, elbow to wrist, rather than round and round to the elbow and discard the towel. Don't scrunch it up because that's now contaminating as well. And those are common things. Traffic in theatre is also problematic. The more people you have in theatre, the more likely there's a wound infection. And we did a study in my theatre where we measured door opening and closing. And during an hour, it was opening 55 times an hour. That's not a door opening, that's a door oscillation, which is interfering with the laminar flow in theatre. Antimicrobial sutures have been introduced and are proven useful. And the most important thing is to keep the patient warm. I've always thought it was funny in cardiac surgery that hypothermia has been excused because we have used it historically as a tool to protect organs. But since bypass is so safe now, I think, like other surgery, hypothermia should be avoided at all costs. And certainly in America, if patients are not coming out in a warming blanket and warm, some people have sued. The other important thing is a dressing. Now I don't mind what dressing you put on, but the dressing, I believe, is there to absorb any exudate, if there is, and for the convenience of the patient, but more importantly, to stop the patient scratching the wound. Because itching is the mildest form of pain, and unconsciously, a patient will scratch a wound. If the dressing becomes oversaturated, indeed change it. But the scratching is an interesting story as well, because after I introduced my bundle, I saw a fall in late wound infections from 5% down to 2% post-operatively at 6 weeks. This is in a group where I had healthy wounds. And the patient came in with a rather nasty, deep sternal wound infection. And I took cultures from this, and it transpired that this was a bug peculiar to potting plants for tomatoes. And that's what his hobby was. So I got him back to scrape his fingernails, CSI style, to send it off to the labs to see if I could match the bug underneath his nails with the bug in the wound. But that was felt to be too expensive and frivolous, and I could not close the circle. But I think it's a good story. And the reason why I halved the wound infection post-operatively, because I used knife only to the sternum. Cautery and diathermy fulgurates tissue, and I believe causes more damage and therefore more pain and therefore more itching post-operatively and therefore a propensity to scratch. So surgical technique is important. Knife only and meticulous attention to diathermy, picking up the vessels only and not cauterizing healthy tissue. Of course, your suture technique, as we have described before, should bring tissues together in apposition and not strangulation. And I watch the junior doctors closing and pay attention to the tension of the sutures as previously described. But what is interesting about wound infection in particular is I would be very curious to know who has got the lowest wound infection in the country. The crazy thing is that information is not available. And I hold this up, which is a picture of maggots, and use this to illustrate the story of positive deviance. Now, positive deviance happens when you find somebody doing something absolutely amazing and you want to know why it is good and try and copy it. And that came to a story for epidemiologists looking at malnutrition in a village in Vietnam, where they could not understand where some children thrived, whereas others failed. And they spent months watching the mothers, feeding, etc., but could not determine what the difference was. Until one of them, in watching one of the mothers harvesting rice in the field, noticed that they were putting maggots in the harvest, and hence the maggots ended up in the food with extra protein, and the babies did better. We know we use maggots for serious wound infection even today because they feed on dead tissue. And another good old-fashioned dressing, of course, is honey or sugar. But as a surgeon, I want you to be curious. Who is doing it the best? What are they doing to make it the best? And I want you to be the best. Because improvement only comes for a restless discontent for the status quo. And that is the story behind the British Olympic team. The British Olympic team did so well one year that people actually thought they were cheating. But what they did is they looked at the 1% of absolutely everything, from the helmets to the bikes to the clothes to the aerodynamics to the nutrition to the fitness, absolutely everything. And the accumulation of improving that 1% of everything was astounding. Now just think of this. If you, as a surgeon, attended to every part of your operation, and we both know there are a huge number of parts, if you looked for that 1% improvement on absolutely everything, wouldn't that be amazing? You too would end up with a flat line. And my challenge now is, even when I get a high-risk patient in who's obese and diabetic with chronic obstructive airways disease and 10 centimeters of fat between the skin and sternum, because my median all wound problem is running at 0, I think to myself, I'm going out on this. But not the case. Attention to detail, attention to respecting the tissue, and I'll continue to run at a median of 0. Now, there are plenty of bundles addressing the pre-op, the op, and the post-op. But the problem is getting people to pull together. And the surgeons are their own worst enemies because they feel maybe in their training they've had to compete with everybody else, but if they've got something that is working with 0 wound infection, I'm much better than everybody else. Or they do not look elsewhere to find out how to improve. And certainly within a team of 6 surgeons, everybody does something slightly different. But when it comes to closing the wound and a surgical site infection bundle, the evidence is there. Why isn't everybody adhering to the evidence? And the story about the Oxford Blues one year is that Oxford had some of the world's greatest rowers ever in the boat. But they did not pull together. And the coach decided to sack them all and got the second team in, much to the consternation of the university, who felt he threw the race away. The second string actually won the race. Why? Because they pulled together. Now, it is a little bugbear of mine, and this is the basis of quality management. Because a surgical site infection bundle is not a tablet of stone. What you need to do is look and examine it and introduce rapid PDSA cycles. Plan, do, study, act, as described by that business guru, Edward Deming. And he was responsible for the success of the Japanese car manufacturing because he standardized and introduced the concept of quality improvement. But our problem in surgery, and certainly in the UK and in cardiac surgery in particular, is that for some reason surgeons getting into the boat in a team are not pulling together. So you, training and aspiring surgeons for the future, I'd strongly commend that you pull together and you regularly do audit, track your wounds, and aim for perfect. Because affirmation and denial on wound infection is abound. But you cannot deny a 10 out of 10 perfect wound. Now, using a simple business metaphor, when they give you a satisfaction questionnaire of 0 to 5, 0 being bad and 5 being amazing, the difference between 5 out of 5 is that everybody goes away and says, wow, wasn't that amazing? And 4 out of 5 is 75% of people say that was good, but they wouldn't talk about it. Do you see the difference? If we as surgeons looked at only perfect wounds and strived to score perfect wounds, and we were prepared to show others and audit it and look for that 1%, I think we will address one of the biggest, costliest, and miserable complications that we see in surgery. And quite frankly, it starts with you. Because, and I love this picture, I've got pictures of a number of tattoos I've put together on people's chests, and this patient gave me permission to use this. Because the perfect wound does not happen on a wing and a prayer. It's a restless discontent for the status quo, attention to the 1% of everything, and above all, respecting your tissue and using your instrument sutures correctly and precisely every time. That is my challenge to you, and sharing my philosophy on wound infection. I hope it makes sense, and I look forward to you joining me next week, where we'll complete this round with harmonization, and my son will join me as we talk further about assisting in theatre, but also introducing you to their non-operative technical skills in surgery and communication, which we know has an even bigger bearing on outcomes. Thank you very much indeed for joining the Black Belt Academy of Surgical Skills. I hope I've stimulated your thinking, Do get in contact if you've got any questions. I wish you well, stay safe, and look forward to seeing you next week. Do keep the pictures coming in. Do share the videos, and I'll put the slides up and a summary on the website. Thank you very much.